Let's take a look at the real procedure done by Dr. Jordan Harp. Whether the patient is upright or lateral recumbent like this patient, identify the landmarks by palpating the posterior superior iliac crest, and where they meet in the midline should be L4, which is good. That's below the termination of the spinal cord, and we don't want to poke the spinal cord, so place a mark at this level. Clean the skin with antiseptic solution, and drape the patient to give yourself a sterile field. Anesthetize the skin with a wheel and then the subcutaneous tissue in the tract that you're planning to pass the needle, and we hope we're right. We know we may have to redirect. While that anesthetic is taking effect, you can get ready, set your tubes up and your manometer if you're going to check an opening pressure. Spinal needles come with a stylet in place. The bevel should be oriented longitudinally with the dural fibers. So if the patient is lateral, the bevel is up. And if the patient is upright, the bevel is to the side. Try to stay midline and imagine that you're aiming right towards the umbilicus or the umbilicus or the belly button. Your needle has to penetrate the supraspinous ligament, which connects the spinous processes, and the ligamentum flavum, which connects the lamina of the adjacent vertebrae. So in theory, 2 pops. In an average-sized patient, that needle is going to be inserted about 3/4 of the way. Might be a little farther than you think. Normal CSF is clear. Try to collect a few milliliters of spinal fluid in each tube for testing. And remember, don't aspirate spinal fluid.
With confirmation of the correct needle location, the lumbar catheter is then carefully inserted 5 to 10 centimeters into the space. The 2E needle is removed over the catheter, ensuring that the catheter position is maintained. Once an attempt is made to advance the catheter should never be withdrawn, given the risk of shearing the spinal catheter. If a rigid guide wire is used, it should be withdrawn by applying a constant light traction. CSF output is now checked from the catheter. The lumbar drain is now dressed.